Good morning, and this is a talk that I have for the core curriculum this morning for our residents, and I'm quite glad that colleagues from within Pakistan and outside are able to join in this live presentation. I'm going to talk about BCG and focus on how BCG has shaped the treatment of non-muscle invasive bladder cancer, and also we'll talk a little bit about what is there once the BCG fails. We're going to focus this talk on the history of development of the BCG vaccine. We're going to talk about the current indication and role of BCG, and then we are going to focus on what is there once the BCG fails. In Institut Pasteur de Lille in France, and developed over a period of 13 years of research after isolating the Microbacterium bovis strain from the cow milk, develop a non-infective type of BCG which can be injected to create immunity against tuberculosis. So this is one of the ads which appeared over exactly 100 years back in 1921 actually. So this is 100 years of BCG, saying that you can preserve your children from tuberculosis by giving them vaccine BCG. And we owe a lot to Albert Calmet and his colleague Guerin, who developed this vaccine. Now, Albert Calmet, who was the director of the Pasteur Institute in Lille, was not only involved in developing BCG, but also was involved in developing snake venom and clearing the sewage contaminants. So he was developing all these strategies about over 100 years back. And this famous cartoon in the Pasteur Institute still hangs there. So these are two gentlemen that we owe for what we have currently, the BCG vaccine, or the Bacillus calmette-guerin. So Albert Calmet and Kamel Guerin. Now, this is about the BCG vaccine. What we use is not BCG vaccine. We use a different form of BCG, much higher concentration of BCG. So how did we come to know that this BCG essentially can be used as an anti-neoplastic drug? So about over 100 years back, end of the 19th century, Coley's toxin, Coley observed that lymphosarcomas are less recurrent in patients who've got bacterial infections. And subsequently, Pearl et al. In 1929 found out that patients with tuberculosis rarely develop malignant neoplasm. So that was an interesting observation. From there on, the pioneering work of Hammad Ather showed that BCG plus chemotherapy can be used for systemic treatment of lymphoblastic leukemia. Now, this was a very significant finding. However, what Mate could not found was that it is not as effective as they thought. So Zabar, again in 1971, this is much later, so 1929 to 1971 is a big gap. Zabar looked at and see why it worked for certain cancers and certain times, but not always. And he developed certain rules. And these rules showed that the disease has to be localized and it is as small as possible. And the BCG should be in direct contact with the cancer. with an optimum dose of 10 raised to the power 6 to 10 raised to the power 8 colony forming unit. So this was Zabar's rule, and this Zabar's rule was used by Alvare Morales. And Morales developed what is called the BCG for non-muscle invasive bladder cancer. So this was a pioneering paper in 1976, so it's more than 44 years back, that Alvare Morales developed and wrote this paper in Journal of Urology about the intracavitary use of BCG in the treatment of what we used to call superficial bladder cancer. Now it is called a non-muscle invasive bladder cancer. So that's an interesting history. From 1908, when Albert Calmet grew Mycobacterium bovis from the cow's milk, to 1976, when Morales described use of BCG for non-muscle invasive bladder cancer. So this is Dr. Morales. So what we use BCG today for is what is high-grade TA, non-invasive high-grade cancer, invasive high-grade cancer, carcinoma in situ, particularly for multifocal and recurrent, and particularly those which are bigger than greater than 3 centimeters. Now, for all these indications, BCG has become the standard of care. Now, how BCG helps in non-muscle invasive bladder cancer? It's by decreasing the recurrence rate. And if we look at the quality of evidence, this is the data from 5 meta-analyses in the European Association guidelines, that BCG after TUR is superior to TUR alone or TUR plus chemotherapy for preventing recurrence of non-muscle invasive bladder cancer. And there is a level 1A evidence. The other problem with non-muscle invasive bladder cancer is progression. So we can progress from low grade to high grade and from T1, TA to T1 or T1 to T2. And this meta-analysis, again, there are 2 meta-analyses actually, which showed that there is a delay and potentially lowers the risk of tumor progression. Again, the quality of evidence is 1A by use of BCG. The question about which strain of BCG is better and which strain should be used preferentially. And again, this is an interesting data. And we know that there are about 10 different strains of BCG which are available at the moment. The quality of evidence is not very good, it's 2A, but it showed that there is not much difference between various strains of BCG in the treatment of non-muscle invasive bladder cancer. So let's take a few cases and see how best we can use BCG. So this is 63-year-old male, non-smoker, history of gross painless hematuria for the past 5 days. This is ultrasound, and you can see a space-occupying lesion on the posterior wall of the bladder. Immediately, because of his age and hematuria and ultrasound finding, he had cystoscopy, and the TURBT was done, which shows a 2 centimeter primary TA high-grade cancer with no carcinoma in situ, right? So how do we risk stratify this patient and develop the best possible treatment strategy for this patient? And we know that one of the most commonly used risk stratifier for non-muscle invasive bladder cancer is the EORTC risk calculator. And this is the EORTC risk calculator, where you look at the number of tumors, the tumor size, previous recurrence rate, etc., etc. And you all know that. Now, what it will tell you by this 5 or 6 very straightforward points or information, that you can develop recurrence point and progression points, and you can then predict with quite accuracy the probability of recurrence at 1 year, 5 year, and probability of progression at 1 year and 5 year. So for this particular patient, with the information available, he had a single tumor. The tumor diameter was less than 3 centimeters. It's a primary tumor. The stage of disease is TA. There is no concomitant CIS, and the tumor grade is high. Recurrence 0.2, progression 0.5. There is about 50% chance that this patient will recur at 5 years, and there is about under 20% chance that this patient can progress to a high-grade disease. Now, based upon this, we know that this is an intermediate risk bladder cancer. Take another case. This is a 74-year-old male, smoker, gross hematuria, which is off and on for the past 6 months, and he would take some antibiotics, gets better, stop his further surveillance, and would forget about the disease. Subsequently, he got an ultrasound, and you can see that the ultrasound has multiple filling defects in the bladder, solid-looking lesions, at least 2 of them, maybe more when we do cystoscopy. He underwent TUR, and the TUR showed multiple lesions, papillary lesion, and some hyperemic areas in the bladder, indicating of CIS. And indeed, when he had his TUR-BT, he had a T1 high-grade disease with no CIS, and the tumor size was 5 centimeters. Again, if we put him into the risk calculator, we can see that there is about over 60% chance of recurrence at 5 years and about 45% chance. So half of patients with similar characteristic are likely to recur or likely to progress to T2 disease within 5 years. So this patient is high risk. 64-year-old lady, another patient, and non-smoker, off and on hematuria for the past 2 years. Ultrasound, sorry, there's no ultrasound for this lady. Cytology ×3 was positive. TUR 11 months back, and there was no record available, and was done, which according to the report was high grade. She was lost to follow-up, and now she has come back with re-TUR shows a greater than 3 centimeter recurrent high-grade CIS. Now, if we put this lady on the risk calculator, you can see that she has more than one tumor. The tumor diameter is greater than 5 centimeters. She has recurred within 1 year, so 11-month recurrence. Stage of disease is T1, concomitant CIS is present, she is G3. And look at this. So the probability of recurrence at 1 year is 60%, and at 2 years is about 80%, and 45% chances of progression at 5 years. So she is a very high risk patient with bladder cancer. So we have 3 patients with intermediate risk, high risk, and very high risk bladder cancer. And let's see how best to treat these patients. So obviously there is very little doubt about, hopefully in the mind of most of you, that this patient, all these 3 patients require BCG. The first one with intermediate risk, you may argue, that patient may be treated with intravesical chemo as well, but I think more appropriate would be to treat them with BCG. Now, if you treat them with BCG, how would you treat them and how long do you treat them? The Dr. Morell's pioneering paper of 1976 shows that you need to give them 6 weeks of empirical induction BCG. Then we have very high quality evidence now available that if you have to use BCG with optimal benefit, then you need to give it in a maintenance schedule. And there are multiple types of maintenance schedule. If you go into the literature, you'll find quite a few of them describe in literature. However, in this randomized controlled trial of over 1,300 patients, the EORTC concluded that patients with high risk, a 3 years maintenance with 3 weekly installation in month 3, 6, 12, 18, 24, 30, and 36 reduces the recurrence rate compared to a 1-year regime. So patient number 1 with intermediate risk may well be treated maybe up to 1 year. Patient with high risk and very high risk probably need very close surveillance, and they should be treated for 3 years for optimum outcome. And this is the SWOG 8057 trial reported over 20 years back and by Donald Lamb, and which clearly shows that BCG with maintenance is much superior. This is a Kaplan-Meier curve, highly significant. And you can see that maintenance versus no maintenance, the survival is quite different. So this is the paper by Dr. Donald Lamb, published in Journal of Urology in 2000, and they concluded that compared to the standard induction therapy, maintenance BCG immunotherapy was beneficial in patients with CIS and patients with high-grade TA or T1 cancers. And the median recurrence-free survival time was as long in the 3-week maintenance arm compared to no maintenance arm. So this is a significant finding, and subsequent trial by EORTC published in Journal of Clinical Oncology, again this is by EORTC, by Lerner and colleagues. And this trial again showed that the 3-year maintenance as a standard of care for high-risk patient. Now, often we ask this question about the dose and how much. So, sorry, before we go into the dose. So, for carcinoma in situ, high-grade high-grade T1 cancer, the BCG optimum is 6 months of a 6-week induction, and then 3 years of maintenance. And this is shown by 2 SWOG and EORTC trials to be much superior than 1 year or other regimens. So again, it's important that BCG for its maximum efficacy should be given for 3 years. And mind you, about 46% patients do not complete 3 years. So the data, so it's not easy to keep your patient on a 3-year regime. So what about dose? Well, should you give full dose, which is depending upon strain. If you have Oncotype 120 milligram, Connaught 81 milligram, etc. So either you give full dose, and this is shown that for patient number 2 and patient number 3, they cannot have less than full dose. So patient number 1 with intermediate risk, and this is the Kyoto study, and it shows that 1/3 dose is as effective as full dose in the treatment of patients with intermediate risk cancer, particularly with 1 or 2 cancers or cancer foci. But patients who have multiple cancers, patients who have higher risk cancer, means high risk or very high risk cancers, they should be treated by a full dose regimen, which is 120 or 81 milligram, depending upon the strain that we use. Let's see another patient, and this is somebody that was recently discussed in the tumor board as well. And this patient is a 70-year-old gentleman who is jointly being seen by myself and another urologist in the city. He was initially diagnosed with a high-grade papillary urothelial cancer plus carcinoma in situ about 2 years back, received 6 induction doses of BCG. However, after the 6th induction, when he was going for cystoscopy, his cytology ×3 were positive, His RETUR, however, showed no growth or no visible growth on cystoscopy, and the biopsies were also negative. However, he had positive cytology, so had multiple biopsies, including those from the prostatic urethra. And it was the prostatic urethral biopsy which basically indicated that the disease is in the prostatic urethra at the moment, not in the bladder. Now, it's important that whenever you have a patient with prostatic urethral disease, you need to look at the histology very carefully, and I'll show you why that histology and the depth of invasion is important in making decision about patients who have got prostatic urethral disease. So this is the normal histology, the submucosal gland, the prostatic ducts, the colliculus seminalis, ejaculatory ducts. This is close to the verumontanum. This is the stroma of prostate with smooth muscles. So whenever you have histology, prostatic urethra, please look at the histology very carefully or read the report at least. This is the gentleman's contrast enhanced CT of August 20, essentially multiple cysts in the kidney, aortic calcification really related to his age. The bladder has some thickening, however, the cystoscopy was negative. Subsequently, he also underwent a PET CT, and the PET CT again showing mild perinephric stranding, and at that time he was actually having bacterial infection. So this is a picture of bacterial infection. There was some discussion about this particular picture on the left kidney, and the discussion with the radiologist, ultimately the conclusion was this is more related to inflammatory process rather than an neoplastic process. So when you're taking prostatic urethral biopsy, it is not that you can take it from anywhere. Right, so look at the biopsy, and you need to identify whether you have a superficial involvement of the prostatic urethra or you have more deeper involvement close to the glands or fibrous stroma, right? So if you look at this slide at the top, this is the prostatic urethral and mucosa, and this is carcinoma in situ, which is going deeper into the prostatic stroma. So this is a T4 disease. This is not prostatic urethral mucosal involvement with non-muscle invasive bladder cancer. And this patient does not respond in any ways to your continuation, reinduction, or other regime of intravesical or intracavitary treatment. Whereas this patient who has CIS, which is more superficial, close to the mucosa, may respond to the intravesical or TUR treatment. So it's really important that you should see what is the depth of invasion of your CIS before deciding whether this patient can be treated by a continuation of less invasive treatments rather than radical cystectomy. So patients with the data is that patients with extravesical involvement by carcinoma in situ has more ominous disease than patients who've got only bladder involvement. Meaning that if you have prostatic urethral involvement, if you have upper tract involvement, these patients are at higher risk of progression and metastases than patients with vesical involvement only. So patients who've got superficial prostatic urethral involvement can be treated by TUR, which means that you create a cavity, make the bladder neck incompetent, so that when you instill BCG in the bladder, you'll be able to have that BCG in contact with the prostatic fossa. And then you start off your BCG with reinduction and maintenance, and then you follow the same schedule of doing their cytology and doing their routine cystoscopies and surveillance cystoscopies. So, but patients who've got prostatic ducts involvement and prostatic stroma involvements have stage T4A disease. And these are the patients who would not respond to intravesical or intracavitary treatment, and these are the patients who should really have radical cystoprostatectomy in order to make them disease-free. And I think we had at least 2 such patients in the last 5 years, and they both had very gingerly accepted radical cystoprostatectomy. One was an executive in a big organization in Karachi and was really very keen to have an orthotopic bladder, which obviously he cannot have. So we did an ileal conduit. He's disease-free. It's more than 5 years now. So 2 more cases for you. Case number 1, 56-year-old male, high-grade T1 cancer with carcinoma in situ, received 6 cycles of BCG. Cytology ×3 was negative after 6 cycles. Surveillance cystoscopy at 4 months, however, showed a low-grade TA disease. Okay, TA low-grade recurrence. Patient number 2, who had a 63-year-old male with high-grade, no carcinoma in situ, had a BCG induction plus 3 maintenance doses. His cytology ×3 was positive, and surveillance cystoscopy showed a T1 high-grade cancer. So these are 2 different types of patients, and these are all real-life patients, and we need to see how to proceed with in these 2 patients. So let me just give you a little background, and then we will talk about how to proceed with these 2 treatment of these 2 types of patients. Just keep these 2 patients in mind. This one had a low-grade TA recurrence. This patient has received 3 maintenance doses after induction, and then subsequently he had T1 high-grade. So patients who've received BCG and who seem to have a recurrence are classified into various groups. So a recurrent non-muscle invasive bladder cancer for whom continuing BCG is unlikely to provide benefit, we need to define these patients in terms of their pathology, when they have recurred, and how much of the BCG has been given, right? So I'll just repeat this. This is important, that the group of patients who would not respond to continuation of BCG and who have had a BCG recurrence or recurrence on BCG, who will not respond to further BCG, should be evaluated by 3 categories. Number 1, they have to have a high-grade tumor to merit as a BCG refractory or unresponsive cancer. It's important that the kind of recurrence should be in a certain time frame. So 6 months and for certain categories, 1 year. We need to see whether they've only recurred with high-grade papillary cancer or they have recurred with urothelial cancer with carcinoma in situ. And it's also important that how much of BCG has been given to these patients. So at least 5 doses of induction BCG with 2 additional instillation should be given prior to you declare them BCG unresponsive, right? So these are 3 important points: the grade, the time in which they have recurred, and have you given them enough BCG to call them BCG unresponsive. So you need to answer these 3 questions before you move on to consider them BCG unresponsive and treat them accordingly. So what are the different categories of unsuccessful treatment with BCG? So there is one category which is called BCG refractory disease. Now, if there is a high-grade T1 tumor at 3 months, it is shown that further treatment with BCG is associated with increased risk of progression. So this is one category. If you have a TA high-grade tumor is present at 3 months or 6 months, well, there is a little possibility that you may give them a reinduction, which means that you've already given them 6 cycles or maybe given them 2 additional maintenance cycles as well. You need to reinduce BCG, meaning 6 weekly cycles and first course of maintenance, which is 3 doses of BCG at 3 months. And if at that point they have disease recurrence, they are refractory. If there is carcinoma in situ present without papillary tumor at 3 months, which persists at 6 months even after reinduction, then again this group of patient is BCG refractory, and presence of carcinoma in situ. In these patients, you would not be able to achieve complete response in over 50% of cases. Number 4th category is that a high-grade tumor appears during maintenance therapy with BCG. And in this group, this is also considered as BCG refractory. So 4 categories of BCG refractory cancers. The other term that is being used is BCG relapsing tumor, which essentially means that after completion of BCG maintenance, there is a recurrence of high-grade cancer. This is BCG relapsing tumor, that it has come back after being completely treated. So this is BCG relapsing tumor. BCG unresponsive tumor is a BCG refractory within 6 months of adequate treatment, or carcinoma in situ at 12 months. And BCG intolerance means there's so much of side effects that you cannot give any further BCG. So these are the various terminologies which are being used. And it's important that we categorize our patient accordingly, according to these current definitions of BCG refractory, relapsing, and unresponsive tumors before we decide what to do next with them. Well, patients who've got BCG unresponsive, which is a global terminology for all these 3-4 categories that we have talked about, the radical cystectomy is the standard of care. So patients who are fit to undergo surgery and patients who are willing to undergo surgery, the treatment of choice is radical cystectomy. Now, what is the advantage of radical cystectomy? That it is oncologically safe. So as far as the cancer is concerned, you are able to take care of that. So if you have acted on time, you recognize the disease, BCG unresponsiveness early, you treat them with radical cystectomy, they're going to have disease-free status. The problem is that it can in certain situations be an overtreatment. So some patients might just have their bladder preserved with some other innovative ways of treatment, but by and large, for majority, it's going to be cancer control, maybe with some compromised quality of life. Now, patients who are unwilling or patients who are unfit to undergo radical cystectomy, you need to think in terms of alternative bladder sparing options, which is effective in some patients. However, there is always a risk of tumor progression. So radical cystectomy, we know indications, we have talked about various categories, and it's important that it is done in time. So this is an interesting work, and you can see that if radical cystectomy is performed timely rather than delayed for this group of patient, there is a significant difference in the survival. So early does not mean early, it means that timely radical cystectomy after recognizing that the BCG is not working for this kind of patient. So cystectomy done at first sign of recurrence is this group, which you can see that this is the timeline, and this is the Kaplan-Meier curve for survival. And there is a significant difference between those who had deferred cystectomy, meaning delayed cystectomy, which is those who had timely cystectomy. So the cancer-specific survival difference between the two groups is 67 and 83%. So if you look at the European Association guidelines, we look at the NCCN guidelines. I think there is very little difference between the two. The language is a bit different. But for BCG refractory tumors, radical cystectomy is number one option. Bladder preservation strategies for patients who are unsuitable for cystectomy is option number two. Again, for high-grade recurrence after BCG, radical cystectomy or repeat or reinduction and with bladder preservation is an option. And similarly, the NCCN guidelines have said more or less the same thing. Okay, so what about patients who refuse cystectomy or who are not fit to undergo cystectomy, or which you think they might benefit from alternative options? Well, there are various types of options which are currently available, and I'm going to touch upon them in the next 5-10 minutes. Quickly, it's just an introduction. We are not going to go into the details of this. There are new cytotoxic treatments in terms of chemotherapy combination, new ways of drug delivery. So you use the same medicine, but you provide them in such a way that it reaches its site of action in a higher concentration and more effectively. And this can be done with certain drug deliverers, and it can be done with the help of device-assisted instillation. And then there is a new area of molecular genetics coming into the treatment of non-muscle invasive bladder cancer with the gene therapy. Use of certain immunocheckpoint inhibitors, and we know about pembrolizumab, the vaccines, oncolytic adenoviruses, recombinant proteins, and photodynamic therapy. So these are all very actively researched areas, and some of these have been reported. Some are still in the process of trials, and hopefully will be reported soon. The problem with the research in non-muscle invasive BCG refractory or unresponsive disease is they have to be single-arm trials. I mean, you cannot really ethically justify a multi-arm study, and they have to be phase 2 or phase 3 trial. They cannot be any phase 1 trials. So there is no gold standard to compare short of radical cystectomy. And the outcome is assessed as 6 months, because majority of these patients, if they stay on the trial for longer than that, there is a possibility they may develop metastases. Now, this is the keynote 057, and any one of you who is interested in going into the details of this, I had a little presentation on the use of pembrolizumab in a keynote 057 trial, and you can go into the PAUS Karachi website and look at the trials, and there is a little presentation on that. So patients who are involved in this trial are high risk non-muscle invasive who are unresponsive to BCG, who refuse or are ineligible for cystectomy. Their papillary disease have all been completely resected. The cohort was divided into 2 groups, one with or without CIS with papillary high-grade TA or T1 disease, and the other one with papillary high-grade disease without CIS. So they received pembrolizumab, 200 milligram, 3 weekly, and then obviously they were evaluated for at 3 months and the routine surveillance with the cytology and with cystoscopy. The primary endpoint was complete response of high-risk NMIBC with CIS at baseline, and the secondary endpoint with CR of any disease, duration of response, safety and tolerability of disease. So at the time of this analysis, and this was approved by FDA in January last year, median about 102 patients, median age was 73 years. About 63.7% patient had carcinoma in situ alone. Prior BCG installation was a mean of 12, so range from 6 to 45. Complete response was noted in 41% with a confidence interval of 30.7 to 51.1. The duration of complete response was 16.2 months. So it's a very good period. For responders, about 46% had a duration of response of greater than 1 year. So those who respond are likely to maintain their response. However, it's a systemic treatment, so it is given not intravesically. So obviously, it has its own side effect profile as well. This is the gene therapy, which is the modern talk about thing in the non-muscle invasive bladder cancer, BCG unresponsive disease, and this is the use of nadofaragene firadenovec. It basically involves a non-replicating adenovirus with a vector-based gene therapy that delivers a copy of human interferon alpha 2b gene to the cancer. And we have this trial being reported, and I'm going to talk about this trial a little bit. So this was a multi-center study, intravesical nadofaragene firadenovec 75 ml once every 3 months in 157 patients for high-grade BCG unresponsive non-muscle invasive cancer, cytology, cystoscopy at 3, 6, 9 months. And at 12 months, all patient underwent urine cytology and mandatory biopsy. Patients were free from high-grade recurrence, were eligible for retreatment. So those who have no response would not receive any further gene therapy, whereas those who have responded would need another dose of the intravesical gene therapy with firadenovec, nadofaragene firadenovec. So this is the details of the trial, and it is reported in Lancet Oncology in November last year. And I've already given you some details of this trial, so I'm not going to go further on this. Just a little for our residents understanding, just a little idea how it works. So essentially, what really happens is that you have a non-replicating adenovirus. So you take an adenovirus, whenever it goes to a host, it will start to replicate. And when it replicates, it causes its typical manifestation of any viral infection. And we know this more than any other time in the history with coronavirus all around. So this adenovirus undergoes recombinant DNA technology, which basically implies that you remove the genes which are responsible for replication, so multiplication. So those genes have been removed, and you have inserted another genetic material at that site. So this genetic material with excipient SYNC3, then a virus cell is administered into the bladder, and the virus infected cells release its DNA along with the adenoviral gene. Now, so this is the essential gene and the complementary cell lines, and this virus, which is a non-replicating adenovirus with an additional gene inserted into the genome of this virus, is placed in the bladder, and it causes the transcription starts, and with the transcription of adenovirus protein, various prototypic anti-tumor activity starts. Now, these anti-tumor activity include anti-proliferative activity, anti-angiogenic activity, and the trail-mediated cytotoxicity. So TRAIL is basically the tumor necrotic factor associated ligand, which causes cell necrosis. So it's a beautiful way of delivering a virus which would not otherwise be able to replicate and cause any viral infection because it's non-replicating, and it will only transcript certain types of protein that you have ordered it to produce. And these proteins have anti-tumor activity. And these are the alpha interferon 2B. And we know that alpha interferon 2B is being used for renal cell carcinoma as well as a systemic treatment. But this is safe. This is in that scenario in the bladder only. And it works beautifully in that area. So this is nadofaragene firadenovec. Then there are certain other things as well which are there besides the use of pembrolizumab and nadofaragene firadenovec, which have been reported, and phase 3 trials have been completed. And these include sequential chemotherapy, the use of enhanced drug delivery, and device assisted installation. So for sequential chemotherapy, use of intravesical gemcitabine with docetaxel have been tried, and for unresponsive BCG unresponsive disease. We are talking about BCG unresponsive disease, and the initial results are fairly good with 56% survival rate in patients who've got at 1 year who've got a BCG unresponsive disease. This is another trial with sequential cabazitaxel, gemcitabine, and cisplatin, and the trial has just been completed and will be the results will be available very soon. So this is another something that can be done for this group of patient. The enhanced drug delivery option is to use certain nanoparticle formulation for your regular drugs like mitomycin and docetaxel. And they are linked with certain excipients, which in this case is urea, and docetaxel and mitomycin C can be given according to this trial and intravesically to enhance, to give it at a low dose and use certain technologies to be able to deliver this much more effectively into the bladder cancer cell. Mitomycin C embedded in TC3 hydrogel, again, another trial which is looking at this drug, which we know very well, but at low dose it is supplied with enhanced drug delivery options using TC3 hydrogel as a carrier, and it would again be able to deliver much more effectively to the cancer cells than otherwise. So device-assisted installation, you can use radiofrequency thermochemotherapy, which is called RICE, which is hypothermia to the bladder wall, and then you provide whichever drug you want to give, intravesical gemcitabine or cabazitaxel or mitomycin, and it will be more effective than otherwise. You can use chemohyperthermia, and we all know EMDA, which is electromotive drug administration. So these are some of the ways in which you can give. EMDA is known for mitomycin C delivery, but it can be used for BCG delivery as well. So the chemohyperthermia using HIVAC is one way of continuous recirculation of mitomycin C for 50 to 60 minutes at a temperature of 43 degrees Celsius, and its delivery into the cancer cell is enhanced. So this is device-assisted installation of various chemotherapy for this group of patient. Various gene therapy and vaccines, use of recombinant proteins like the one that we have talked about, the use of pertuzumab, Manatox, again is being looked into, and hopefully we'll have some more effective drugs available for the treatment of BCG refractory disease in the coming future. And as you can see, that a lot of these are now a possibility. So in conclusion, if you look at the current EAU guidelines, offer radical cystectomy to patients with BCG unresponsive disease, and there is a very strong evidence. However, the evidence for candidates who are not fit for BCG, for radical cystectomy, or not willing for radical cystectomy, or may have some of these other things that I have talked about. But again, the quality of evidence is weak at the moment. So in conclusion, this is the 2021 guidelines by EAU that BCG unresponsive, option number 1 is radical cystectomy. And option number 2 is that you enroll them in clinical trials with new drugs with use of certain bladder preserving strategies in patients who, but again, the evidence is weak. Late BCG relapse, radical cystectomy, or repeat BCG, depending upon individual situation. And I have shown you cases, you need to really tailor your treatment accordingly. Okay, so I'll stop here and thank you very much for your attention. I'll be happy to take if there are any questions.
Dr. Hammad, you were about to mention why, so the importance of 5 and 7 o'clock biopsies before the breakage.
Yeah.
And then you never got back to it.
Okay, so the 5 and 7 o'clock biopsies are the ideal site for biopsy, because this is the site where you have the highest chances of picking up the cancer. And the reason why is that it is the shallowest area of the prostate. This is what I can think of. And the chances of invasion into that area is highest. Also because there are ducts opening, the ejaculatory ducts opening into that area. And probably for all these reasons, there is a higher probability of finding cancer or carcinoma in situ in prostatic fossa than any other area. So, so if you have to do a random biopsy and there is nothing really visible, the best site to do it is at 5 and 7 o'clock. I hope that answers your question.
Yes, thank you.
Excellent talk, Dr. Hammad. Thoroughly enjoyed it, early in the morning. Just kind of, for completion's sake, could you elaborate, like most of our patients are elderly patients. Do they tolerate BCG as well as kind of, the younger, or is BCG as effective in elderly and immunocompromised population?
Puram, that's an excellent question. The age I have, at least in my, and whatever I've read, age is probably not the reason for BCG intolerance. So I have patients who are in their 80s, and one of this patient is an ex-ambassador of Pakistan who is 83 years of age, and he tolerated it wonderfully. It's only that he came to me a couple of weeks back saying that I'm really tired of this thing and I want to be off. I know that I'm taking a risk, but I want to stop this. So in my opinion and in my clinical experience, the age I have not seen as a significant risk factor of BCG intolerance.
Effectiveness as well, because it all relies on the immune response which you generate.
Yeah. So as you're saying, this is basically immunomodulating agent, and the reason why it has worked for various cancer historically is because of its immunomodulating effect. In fact, there is a lot of research now, and I was just looking at it last night, about use of BCG, systemic BCG as a vaccine for COVID-19 patients. So
Yes.
you're absolutely right that in order to enhance your ability to mount an immunological response, you need to have a competent immune system. So this is what Dr. Khurram is pointing out, that you need to have a robust immune system to be able to mount a response once excited. So it's like being, you excite with the top model, 30-year-old versus an 80-year-old person. You can guess who would get excited.
You remember there was a initial enthusiasm in BCG plus interferons.
Yes.
Study from somewhere in Ohio, Dr. McDonald. Yeah.
Yes.
Thank you very much.
Thank you very much, Khurram. Thank you for your comments.
Dr. Hammad.
Yes.
Yeah, thanks for nice presentation. I want to just comments about clinical experience about the maintenance therapy. In your clinical practice, how much percentage they maintain this 3-year program in your clinical practice?
Okay, so if we look at the data, only 46% in the best of centers, and where insurance and health system and health plans are there, and you have worked in Canada, you know that with the state providing and people working in NHS, again, state providing or insurance system. So basically, even in the best of system, the 3-year maintenance is seen out of trials in real life situation, not more than half or even less than half of the patients. If you look at our own personal experience, it's not a big experience, but again, I would confess that it's very rare patients who have actually completed 3 years of maintenance therapy. At best, if I'm able to do it at 1 year, I think 1 year is something that a significant proportion have accepted and stayed religious on 1 year. But 3 years, you're absolutely right that it's a very small group which actually completes 3 years.
Thank you.
Okay, seems like there is no other question. We have already crossed, we are at 9 o'clock. So thank you very much for your attendance and for your participation, and have a good morning.